There's a rising interest in early onset colorectal cancer, and this has to do with the fact that in the United States, as well as worldwide in developing countries, we have noted an increase in the incidence in patients under 50. So this is a patient population in whom we don't have screening guidelines. In fact, we don't recommend screening until 50 or older, and yet they are developing colorectal cancer. And some of the questions that arise, of course, are what are the predisposing factors? What's interesting about this population is that they are not all familial. So we know that patients with Lynch syndrome, patients with ulcerative colitis have an increased incidence of colorectal cancer in this young age group. But these patients don't have any of those predispositions. They don't even necessarily have any family history, or certainly not a family history of cancer in relatives younger than 50. So something is going on. There is very likely an environmental factor that is contributing to this rise. And what's interesting as well, and that some of the data that were presented at this meeting and also from the prior publications of the SEER database, is that these tumors appear to be predominantly left-sided, predominantly rectal. And we really don't know why that is, if there is perhaps a different driver, whether this is obesity or whether this is microbiome driven. Those are some of the research questions that are still ongoing and some of the things that were discussed at the meeting today. The major take-home point at this time for community oncologists, but even more so for internists and gastroenterologists and primary care providers, is not to dismiss symptoms of rectal bleeding, bloating, abdominal pain. That is how the majority of these patients present. That was clearly presented at today's meeting as well at GI ASCO. And so to see if these are the symptoms, to follow them up, to recommend a colonoscopy. At this time, I think it's too soon to say that we should do screening 45 and older or 40 and older, simply because although the incidence is on the rise, it's still low relatively to the population that would need to be screened. For community oncologists, the data suggests that these patients present with more aggressive tumors. There have been some data that they don't do as well. They present with later stage. It's really unclear whether they present with later stage because their disease is more aggressive or because they actually dismiss their symptoms until they develop advanced disease and then are diagnosed at a later stage. We don't know very much about how they respond to chemotherapy. Some of the data at today's meeting indicated that they actually do better per stage as compared to average onset, possibly due to improvement or a better ability to tolerate chemotherapy, possibly because their disease is more responsive. I think it's really a question of the biology, and at least what we've seen so far, including the analysis of the oncotype DX in early stage patients, there really didn't seem to be a very significant difference between the younger patients and the average onset who are in their late 60s or 70s. So I wouldn't recommend a change in treatment at this point for community oncologists. I think younger patients, from the data presented at today's meeting too, are treated a bit more aggressively, are more likely to get chemotherapy, but that is probably a combination of the oncologists trying to do what they can to treat the disease, and then also from the patients wanting the most aggressive, being very motivated and wanting the most aggressive treatment.